Okay, good morning, everybody. My name is Mary Jane Burke, and I work at the County Office of Education. I want to welcome members of our community here for another opportunity to hear from our public health officers, Dr. Willis and Dr. Santora. The focus of today's presentation will be the science. As we look at the opportunities we have to reopen our schools and get our staffs and students back into the classrooms. Just as a reminder, this session is being recorded and will be available to you by tomorrow for sure to share with others. Also, there's a phone number and we have someone translating in real time this in Spanish, so that's also available. The time we have allotted is 1 hour, and so we will actually be stopping right at that point. Wanted to remind you as well that next Thursday and the Thursday after at 9 o'clock, we will be having similar sessions with Dr. Willis and Dr. Santora, but our focus will be on the site plans for our schools and looking at the 30-point plan that's been provided in the guidelines so we can begin to talk about each and every aspect as our schools develop their particular plans. So we look forward to hearing from our public health officers. Thanks to all of you for providing to us the questions. We received a lot of questions, and so they have been provided to Dr. Willis and Dr. Santora. We have over 500 persons participating at this time, so we really appreciate your interest and care for our community and our schools. So with that, Dr. Willis, I'm happy to turn the screen over to you.
Thank you, Mary Jane. Good morning, everyone. Matt Willis, Public Health Officer. And I just want to echo what Mary Jane started with, which is, this is the beginning of what will be an ongoing dialogue around how we tackle reopening schools in August. We've offered recommendations last week, working with the Marin County Office of Education and Public Health, have developed a set of guidelines and recommendations for how schools can reopen. And I want to be clear right off the bat that that this is again, these were recommendations. Most of what had proceeded in the shelter-in-place elements from my office as public health have been in the form of orders, including one of the first orders in the state to order the closure of schools when we were seeing surges in cases. At that time, schools would have been free to do something more restrictive to close schools based on the school or the school district. Once the health officer order came to close schools, schools were not then permitted to open. In this context, these decisions will be ultimately navigated by schools and school districts, and I, as public health officer, working with the Office of Education, and you all, hopefully collaboratively, will determine what's appropriate for your setting, with that goal of, as much as possible, getting children back into the classroom. So I've just offered some, so today we'll be looking at some of the science. Mary Jane was able to collect some of the questions that have come forward. I'm going to answer some of those questions by way of a presentation, and then we'll get to some more open question and answer. This is the mission of the Department of Health and Human Services, where I work. Promote and protect the health, well-being, self-sufficiency, and safety for all in Marin. And I am a government employee. My salary is paid by taxpayers, and I see myself as a public servant, and I sit here as a partner with you in trying to just make our school environments as healthy as they can be. This is the way I think of health. I think our department views public health as being far beyond just simply physical health and the absence of disease. And I think the best description of that comes from the World Health Organization, which defined in their constitution in 1948 that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And I think navigating these questions around reopening schools really brings the holistic sense of health and well-being into special relief, because we're organizing this not simply around the prevention of the transmission of COVID-19. If that were our only organizer, we would really simply be remaining in place. We would be sheltering until there was a vaccine available. And I think we all societally understand that that's not a feasible approach. And as soon as we begin to reopen, we're entering into conversations about what do we value and how do we mitigate risk. And this is just along that continuum. So here are some of the shared values I just hope we sort of agree to in this ongoing dialogue. We obviously value health in that holistic sense of health, as I just described. We value education, as a nation, particularly as a community in Marin. I think we value high quality education. We value equity. We value looking at science and evidence. We value choice, personal choice, institutional choice, and we value dialogue and communication. And that's, I think, the spirit of this conversation and the weekly conversations we'll have is to promote that sort of back and forth dialogue we need to make the best choices collectively. The shared challenges are that we are all facing uncertainty. This is a novel virus. We have about 6 months under our belt totally, collectively, globally on this. And so we're still trying to extract every bit of science and data we can to learn about this virus and apply that to our local context. There's fear of what it might mean if we come back into schools and there's transmission in that setting. Fear of the unknown about what the virus actually may represent in terms of the long-term consequences. And we just need to acknowledge that as part of the environment in these conversations. We have no zero risk options and we need to be adaptable. So as I mentioned, there are continuums of risk. That's the way I think, rather than expect that they're sort of easily categorizable risk. These are continuums of risk where we're taking into account the risk of COVID-19 infection, the risk of other physical health that might be associated with one strategy or another, the risk of mental health if people are not coming to school or coming to school, social health, learning and development, and equity. And all of these are different continuums. And if we make a decision to say not return to school, what is the risk on that continuum of risk socially? Where does that put us versus the benefit for reducing COVID-19 transmission? So these are the questions I'm going to try and answer. These are some of the questions that came up today or came up over the course of the past week that Mary Jane offered. Are children as easily infected as adults? What is the clinical severity of infection in children? How do school closures impact community case rates? What has been the experience with cases in schools thus far? And how can we talk about reopening while cases are continuing to increase? So this is a fortunate study that was just published in Nature, which is one of the primary science journals, just last week, or June 16th. And what they did is essentially try and answer the two of those questions. One is what is the risk of infection for children, and the other is what is the clinical severity of disease in children. And they were able to take advantage of the sort of the collective acquisition of data that's happening globally now by looking at cases from China, Italy, Singapore, Japan, Canada, and South Korea, and looked at infection rates among people of different ages with similar categories of exposure, and then looked at the clinical severity of disease among people of different ages. And then they modeled the impact of school closures on population-wide incidence of disease. And I won't go through all the methodology, but just to the conclusions, is the questions, are children as easily infected as adults? And what they found is that when they looked at cohorts of children that had the same level of exposure as adults, that susceptibility to infection in individuals under age 20 was approximately half of those above age 20. And that's shown on the lower left graph there, which showed that on the bottom axis, you see age. And basically with increasing age, there's a higher risk of becoming infected with a given level of exposure, where at about 50 years, people above age 50 are at a higher risk of actually becoming infected with a given exposure, which is different than the question that we've always been talking more about, which is the risk of severe illness if you're infected. They also answered the question, what is the clinical severity of infection, or at least partially answered that question, and determined that clinical symptoms manifest in 21% of infections in 10 to 19-year-olds. And that proportion of people who had clinical symptoms, which is basically someone who is symptomatic with COVID, symptoms consistent with COVID-19 infection, who seeks medical care and is diagnosed, that number rose to 69% of people above age 70 in this study. And just to correlate that briefly to Marin, what we see is this is our current data with our now 1,000 cases since the beginning of the pandemic in our county. So we're now developing a kind of a robust data set within our county, and we've used that to do a lot of the descriptive epidemiology locally, which has informed our decisions, which I'll share with you. But on the left there, you see the column that shows our population breakdown by age. At baseline, 21% of our population is below age 18, 16% of our cases, but only 3% of our hospitalizations and none of our deaths. And this also shows on the other end of the spectrum what that study showed in terms of clinical severity, which is, our older ages above the light blue, 65 or older, is 16% of our population. And people in those older ages make up 100% of our deaths and about 35% of our hospitalizations. So how do school closures impact community case rates? This is from that same study where they aggregated data across multiple countries. And this was some of the modeling for different cities based on different demographic profiles of those cities. And essentially what they found is that school closures have limited effect on population case rates. And what you show here on the solid lines is the scenario when schools are open, and the dotted lines are the scenarios when schools are closed. What you see is the spikes in cases are similar in both of those scenarios. And then the 0, 50 to 100% relates to how infectious someone who is not having symptoms might be to others, which is an unanswered question. And which is why they offered 3 different scenarios, because once we have better answers to that question, we'll know how to apply these models better. This is a crazy looking graph, but it does offer some insights. And what this is a description of every country where they have long-term prospective data before and after schools reopened. And what it shows there on the time axis, on the bottom axis, is at 0 is the beginning of schools reopening. And then you just see over time how that affected the incidence within that country. So these are national reopenings, which is different than the United States functions. We're state and even local decisions, but in many countries these are national decisions, and you have much more robust power to measure the impact across large numbers of across large populations. And what they essentially show is that there's no statistically significant impact of large-scale school reopenings on national prevalence across the globe when schools have reopened during COVID-19. Some countries that go up, some go down, and it's not significant. Then how can we prevent spread in schools? This is a study that was recently published out of Australia, and kind of an elegant little study. What it basically did was just take the number of infections. I think there were 12 cases or 14 cases in schools after they had opened schools of COVID-19, and then looked at, in each of those cases, the corresponding cohort of people who are close contacts, and they're represented graphically here. So student cases are the green circles. There on the upper left, you'll see 2 student cases. And then the rest of those figures represent the number of individuals who had close contacts with them within the school setting. The red circles represent a secondary case. That is the people who are infected by those individuals. And so with those, in this school, for example, there was 2 student cases, and they saw after that 2-week interval and the thorough contact investigation identifying over 100 close contacts, that 1 other student was infected, and that's that secondary school case. And then each of those other boxes with different cohorts represent different cases in different schools. This graphic shows high schools. And the corresponding classrooms or close contacts that went along with those. And what you see is that for all of these cases, there was only one episode of transmission within the school setting at the high school level. and out of 863 close contacts. And no staff were infected secondarily. This was that same methodology applied in Australia to primary schools. And what they show is that the blue circles are staff cases, and then the corresponding close contacts. And what we see is that there was one secondary student case based on a staff case, and no other secondary cases within schools. So these are some relevant questions also that have been in our minds, in my mind, as we've thought about how to approach reopening schools. With smaller cohorts in school on fewer days, we had talked about cohorts of 12 based on the childcare model that we developed and the camps. We're also seeing that when we do those small cohorts of 12, there's fewer days that children can actually be in the classroom together. So what happens on those days where they are not in school? And is there more mixing of children through the week? And what we found is that when it was suggested that there would be small cohorts of 12, even though that was a model that we were just thinking about and hadn't endorsed as the way we would be approaching schools in the fall, we did take that approach for summer. There was a lot of dialogue around how parents would come together to manage children on the days where they weren't in school. And that the concern was that would actually lead to more net mixing across this week, unless every child could be alone at home with a parent helping them, shepherd them through that distant learning process. We might actually not achieve our goals in terms of limiting net mixing by having a purist approach to small cohorts within schools, not recognizing that what happens outside of that setting might actually undermine those public health goals. And if so, would it be equitably distributed? Would every parent, would every household have the ability to actually keep someone at home to make sure that that child is there without mixing with other children and getting the distant learning experience they deserve? Secondly, with the decision to resume in-classroom learning, what is the added risk moving it to every day? So this is another, I think, important organizer for our discussions, which is once we have made a decision to move children into classroom settings where you have adults mixing with them, so much of the work that we need to do to actually do that safely has already been conducted, because to do that at all requires that we're going to have to be on our A game regarding symptom checks. All of the personal protective work has already occurred just once we've crossed that threshold from a pure distant learning closed school environment to an environment where we're already recognizing that we're going to be coming together within the classroom. And then finally, besides distance learning, how can we achieve the goal of fewer children in the classroom? If that's one of our primary drivers, is to decompress or de-densify the classroom itself in terms of the architecture and the numbers. One option is distance learning through technology, children being at home. The other is moving things out of doors, outdoor classrooms, outdoor learning in parks. And this is an important movement that's moving forward regionally in the Bay Area, where they're thinking innovatively with other San Mateo, Santa Clara, Alameda, thinking innovatively about how to optimize outdoor settings within the school campus to achieve some of that social distancing. Okay, I'll end with this bit. How do we talk about reopening with cases while cases are, oh, that's right. I was going to have Lisa talk about our experience in our cohorts to follow up on the Australia study where we actually showed the impact of cases within a school setting. We actually have experiences within Marin for that, and Lisa can summarize that. Thanks, Lisa.
Sure. So we partnered with the Marin County Office of Education to launch the emergency pop-up cares at the beginning of closures. We recognized the need that essential workers in our community, including myself, needed childcare options. And in order to provide the care in our system for all essential workers, from sanitation workers to physicians to other childcare providers, that we needed to have a childcare option. So we worked closely to develop cohorts of 12, which have been running since March, and we have over 4,000 student days in these cohorts that we have experience with, and over 700 cohort days. of all those days that we had students attending, and again, implementing screenings, things that we'll talk about, the personal protective strategies that we have to prevent the spread of the virus. And we do have a lot of strategies that we have control over, even though sometimes it feels that we can't control COVID, but we do have a lot of strategies to protect ourselves and our families. We only had to close just right above 2% of our cohort days. And that is because we have a very aggressive strategy that we're implementing that we do not implement with other viruses like the flu. Moving into the new school year and our practice throughout the summer camps, as well as the spring pop-ups, childcares, is we have an isolation and quarantine protocol where if one student is identified as positive or one staff is identified as positive, that entire cohort closes. And I think this is one of those, again, an important public health strategy that we have as we are reopening school, to have this aggressive containment strategy of isolation and quarantine. And in all those experiences, we only had one child-to-child transmission, and it was a much younger population group. The challenge for the parents, honestly, in this experience is that the children had very, very mild to no symptoms. And so parents had to find strategies for childcare when they had a child who no longer manifested any symptoms of COVID-19, but had to stay out of the cohort and out of the school environment. And I think this just affirms the study from Australia with data that we have from Marin County, showing, again, reinforcing that there's something that's important to us as we start looking at data is that studies are replicable. So we're seeing the same outcomes in multiple studies. And the numbers that I just described from Marin County in our pop-up is very similar to what is described in the Australia study. And we look forward, although it was a crazy graph to look at, that's showing us that there will be more research that shows us what is happening in the youth populations with schools and different strategies. And I think that will be part of the changes that we see. And as we learn more about the disease, is also how long do we maintain this very strict isolation and quarantine strategy for our cohorts, which again is an important tool. So that's it.
Thank you, Lisa. And Lisa will come back and answer some of the questions that were asked about some of the protective measures we can take at the school setting. But I want to just take a step back now to look again at the big picture for Marin. Many of the questions related to this fundamental question of how can we talk about reopening while cases are increasing. And I just want to share, some of the data, and this will be one of the principles I think will apply to this conversation ongoing is continuously sharing the real life data that we're seeing and collecting on a daily basis, and trying to offer context for that and see how that might modify our strategies with regards to schools. So this is the total number of cases. This is available at coronavirus.marinhhs.org. It's updated about 4 o'clock every day. And there's a lot of interesting and important information there for anyone who's interested in helping track this with us, and your ideas are always welcome. So this is the total number of cases we've had. We just crossed the threshold of 1,000 cases as a county. And the bottom line there, yellow, is the total number of hospitalizations, and then the bottom red is the total number of deaths. To offer a little more context for that, this is the number of tests that we've been performing on a daily basis. And what it really tells the story of is a lot of that increase in case rates is attributable to dramatic increases in testing. We knew that across the nation we really were not testing nearly at the rates we needed to diagnose the illness where it was occurring, or even begin to have the sort of the descriptive epidemiology we needed to have more targeted strategies, because we weren't testing broadly enough to determine the racial, demographic, community-based factors associated with illness. So that's a problem that we are, I think, well on the way to solving by testing on some days up to 800 individuals in the county. And so that's important context for, as one of the drivers of increased testing, increased case rates. This is also important context, which is that increased case rates has not been accompanied by surges in hospitalization rates or death rates. In fact, as we see more cases, the proportion of people who are hospitalized per case has been declining steadily over time. This offers another level of precision. Again, I think that question of how can we reopen while cases are increasing, we have to look at the totality of the evidence to understand where the virus is flowing and whether or not we feel so confident that we have strategies to address that, rather than, if we just had sort of an uninformed and holistic sense that it's surging, we might just have to make a decision to shut down unless we understood more specifically about what are the actual determinants with more precision. And in this case, I think we have a really clear description of the particular dynamic that's driving the cases now, and can feel reassured that that's something that we can strategically address while we continue to reopen carefully. And this slide demonstrates, I think, what a remarkable reality for us in Marin County, which is almost all of the attribution of the increase in cases since really mid-May in Marin County is among people who self-identify as Hispanic or Latino who are younger age. So it's younger Latinx people who have been on the front lines as essential workers, and then becoming infected in that context, perhaps at the workplace, perhaps through interface with the public, especially if they're not able to practice all of those measures that we think are so important. And then bringing it back into households where it's amplified at the household level. And if you look, at the bottom, so those bottom lines there, what it shows is the different age ranges, and then Hispanic, Latino versus white population. And it shows that basically older ages of any race or demographic group has had very little change in the incidence over time. This is also an important piece of context, which is it shows the hospitalization rates and death rates over different time intervals. And what we're showing is that early in the epidemic, 17% of our cases were hospitalized and 8% died. This was in the early days where we were really only testing people who were more severely ill, people were coming to the hospital. And the average age of cases at that time of cases was about 56 years. As we've done more testing and we are starting to find more and more asymptomatic cases, from mid-May to the present, 3% of our cases have been hospitalized, and the mortality rate is 0.4% among cases. And the average age of the cases has declined to 34. So the primary driver, just to be clear that we understand currently what's driving the incidence, is it is a population, as I mentioned, primarily essential workers. The index case for a household, so the person who brings it into the household has been an essential worker. There's transmission within a household. We're seeing a much higher proportion of asymptomatic or mildly symptomatic people, much lower hospitalization rates or mortality rates. And our strategy there is to partner with community-based organizations, strong, aggressive, bilingual, bicultural capacity. We're building up that mainly through relationships with faith-based and other organizations who work in those communities directly. Outreach to employers and community employers who employ essential workers, and the community itself. Aggressive testing, contact tracing, support for cases and their families, including income support, housing, food, and healthcare. And I'm just going to end with this because it's been in the news and everyone's quite concerned about San Quentin. I think they just crossed the threshold of 500 cases there over the past 2 weeks or so. Or maybe it's 556 cases among inmates and then another 50 or so among staff. 122 inmates were transferred from another prison outside of Marin County that had been exposed. They were essentially placed in that facility and triggered an outbreak, unfortunately. And we've been watching this unfold. In some ways, and the reason I want to share this, in some metrics that you'll see, these cases are counted as Marin County cases. And so Marin County will soon become sort of a hotspot statewide, because we could easily see more cases just in San Quentin than the rest of the county combined since the beginning of the epidemic. And it's important to make a distinction because it's an epidemiologically unique environment and does not place risk to our community as a whole in terms of transmission. We're working with them to develop a surge plan for on-site care for inmates who may become ill. So here's our challenge. How do we safely continue to reopen knowing the virus is part of our environment? And the answer is we do it carefully, we do it together, we optimize our self-measures, We recognize and mitigate risk. We know that there's no zero risk options. We follow the data. We remain adaptive and flexible, and we rethink our assumptions about how things are done. Thank you. And we can do it. That's my Wade Thomas, soon to be fifth grader, Basil. Why don't we, do you want to, Lisa, answer some of the questions that had come up regarding preventive measures, and then we can open up to questions?
Sure. So I think this is, again, us working together. The preventive measures, some of them are the basics that are always our preventive measures as we re-enter into the school year. And a lot of it starts with home. I'm a mother that has my kids now in camp, and because of my position, I've always been the mom that keeps her kids out of school when they're developing any symptoms, because I know I have scrutiny in my position to make sure I'm not sending my sick kids to school. And again, that's where a lot of this starts, is where parents and families first really need to continue limiting their social activity. It's a hard message to hear, but as things reopen, that is not encouragement or recommendation by our department to go out and increase all of your social activities and engagements and reunions throughout the summer. It really is a time to just increase activities in order to ensure your emotional and physical well-being for your family, but it's not intended to have mixed gatherings all of the time. And so that's the first strategy, is really limiting our social activities, maintaining the social bubbles that were described last week. And again, these reopenings is not a prescription to go out and gather. The second is the measures that we have in place when we are gathering, again, trying to maintain limitations in that gathering and protecting ourselves and protecting the transmission or spread to others. And we have two key methods for doing that. One is face coverings, which you have all seen become universally available. And I know it's a hard decision when you start regathering with individuals, those in your families or other families, but wearing face coverings and maintaining that 6 feet distance. These are all erring on the side of caution. The viral particle, that DNA, needs human biology to replicate. So it really depends on us introducing viral particles from someone's cough or respiratory droplets into our own body by touching our face and our hands, touching our face with our hands. And again, so by maintaining social distance or physical distance and by wearing face covers in your regular practice before you ever start school, that's going to maintain and continue to flatten the curve and reduce the spread of disease in our community. And again, reinforcing before you ever get to school, hand washing. Parents and educators, all of us have to continue to double down and stay vigilant on hand hygiene. We are horrible hand washers. I was just at a work site last week, re-educating adults about the importance of hand hygiene and how to wash our hands. That's how we introduce this virus into our system. So again, we have a lot of control within our own family units to reduce our social activity and to practice good hygiene and model that for our children and for our students and for staff and for each other before we ever enter into the school doors. We are recommending, and we launched this with our pop-up care where it is screening on entry. There is some risk and benefits of those temperature screenings, but we're still recommending the screening and asking parents if they've had any known exposures. Are there any symptoms? Again, we have a tendency to always attribute things to allergies, and this is not the time to attribute everything to allergies. If there's any time you yourself feel a nag in your throat or hear someone feeling that way, the recommendation for us would be to go and get tested. We also are recommending that people that are out in the public and working get tested at least once a month. That's a strategy that we've used. And again, we have expertise in this because we were working with our most vulnerable populations, our nursing homes. And they've been very effective strategies. Marin County, fortunately, knock on wood, has not seen the evacuations of nursing homes or the large scale deaths in some nursing homes that you've seen nationally. And that's because we have a very aggressive strategy for cohorting, isolating, quarantine once we identify anyone is a person under investigation. getting testing done immediately. That was not available to us in March, but now we can get an individual tested and self-scheduled tomorrow, even as quickly as tomorrow. And if you talk to your healthcare provider, tested possibly even the same day, and have results within 1 to 2 days to inform our public health measures for reducing the spread in the classroom environment. Again, there'll be face coverings. We saw guidance issued from the governor last year. It exceeded what I expected, last week. It's not last year yet. Last week, it exceeded what I expected, where they're recommending that children over the age of 2 wear face coverings. And that's going to be a new challenge as a parent. It's something I struggle with, the 7 and 9-year-old. And I know it's going to be challenging in the school environment. I see it every day. And again, that's us working together, encouraging each other to wear face covering appropriately and to model that. And then to really avoid touching the face covering and wearing it inappropriately. And I think that those were strategies that will be able to work together with school districts and school sites to develop the educational materials that are necessary at every level of the school to make sure that those best practices are in place. Again, it's amplifying our cleaning, the guidelines that the MCOE is developing and that will be working with schools at the school level and the school site level is really amplifying cleaning and disinfection. It takes more time. It's a practice that we all are responsible for our own workspace. And again, educating ourselves, modeling that behavior so we have clean workspaces for ourselves and students. And again, those are strategies that we will begin working with the districts. A lot of the efforts can start now in changing how we ensure that we are working in clean environments, ensuring that we're not bringing and introducing the virus into our school community, and staying vigilant as we move forward. At school district levels, we've already seen safety committees engaging in the work, thinking about the school district and we know each school district is unique in its population and its buildings and different challenges that may be unique to each school district. And so there will be a community of learning at the district level that will be shared throughout the county level. And then also, again, really encouraging those school site councils, which are just invaluable resources to think specifically about the schools and innovate. I had started having conversations now as parents have gotten their head around the idea that school is reopening. There's some tremendous ideas that are out there that may require some foundational support for implementing or additional parental support. But this is a pandemic. We all have to work extra hard and work extra hard together to identify creative strategies to get us back to this new normal. And again, this is very much driven from an equity lens. We've seen the educational gaps increase during this time of closure. And in order for our community to work together, we need to make sure that every child in our community has the best opportunity to learn. And this is essential work. Our teachers and our school staff are so essential to who we are as a community. I think it shows just in the numbers of people that are attending today, how vital school is to us being a healthy community. And we can do it together. There'll be bumps along the ways and changes along the ways, but we're upstaffing in the public health department, bringing on more nurses specifically to be prepared and ready to provide the supports to the schools as we enter into the new school year. So, yeah.
Okay, great. Great, thanks, Lisa, appreciate it. How about if I go to some of the questions that we're seeing in the chat? So Dr. Willis, I guess this really is to both of you. Can you reassure us that you will recommend closure of schools if it's not safe to open?
Yes, absolutely. I mean, this is, we're forecasting just some context in terms of the timing. For the Marin Recovers group, we're forecasting, week intervals, 2 weeks for the incubation period. So to be asked to predict, August, as soon as that is, and obviously it's so important from a planning perspective, but mid-August in COVID time seems like it's a long ways away. And just to be honest, and transparent about this, I don't think anyone can tell us what the world will look like with regards to COVID in California at that time. These decisions, I'm not making these decisions with you all in isolation. This is obviously been present in the mind of, nationally and at the state level. The governor has, made an important announcement yesterday with requiring facial coverings and potentially beginning that conversation about maybe rationing back on some of the rapid reopenings that have been occurring. So this is right at the forefront of our minds is what steps would we take into these broad social policies, school reopenings, other sectors opening or closing with regards to transmission and incidents. And yes, if we're seeing surges in cases and it's frankly unsafe, then yes, we know how to do this. I mean, that's the other, we were among the first counties to close schools when we started seeing exponential growth in cases. One of the questions that came up was, what's different now? And I think there's a lot that's different now. I mean, we know so much more about this virus. We now have the surge capacity. Our hospitals are, less than half capacity right now. We've got at least 56 COVID-19 beds. Right now, 9 of them are occupied. We've got 420 total beds. And then we have 100 bed capacity of an alternate care site we've already built. So that's been built. We have contact tracing. We have now more than 50 people who are able to do the contact tracing. We're doing like 600 tests a day. Our testing capacity has increased. There are now treatments available. Three patients in Marin County now have received treatments and survived COVID-19 infection that would not have been available 2 months ago. And so all of these are important, I think, contextual factors for allowing us to move forward with a little more confidence, still recognizing that we need to do it slowly and cautiously. So yes, we would close schools if we were seeing surges in cases that were overwhelming our hospitals, for sure.
Mm-hmm. A couple of questions about testing. Is there a chance that a blood test will be available, number one, or a different test? And number two, can a school or employer require someone to take a test? What if someone doesn't want to take a test?
Yeah, the PCR test is the best test for diagnosing infection. There are other methods, though. There's a saliva test. There's less. I mean, if the concern there is the sort of the brain tickle, which is the deeper nasal swab. I think some people are afraid of that kind of test, and I've had that twice, and I see why. But it's not that uncomfortable, and it's over quick. But there's one that also goes just into the anterior, not quite as deep, that is now getting more popular and is being used more frequently. And that's also available. And then there's antibody testing as well, which I think is an important question mark for us, but may answer some of these most important questions with regards to schools. If we end up with an antibody test that's accurate, sufficiently accurate, and once we understand what immunity represents, if someone does actually have antibodies, that's my situation having had COVID-19. Is I know that I've taken the antibody test. I have antibodies. What science can't tell me yet is what that means in terms of my protection. Am I at risk of being infected again? Could I become sick again? Once those questions are answered and the answers are emerging, and it's looking encouraging that antibody positivity does actually confer some level of protection. That's a tool that we could use in school settings to determine teachers who may or may not be vulnerable based on having been exposed and infected in the past, and students as well.
Is it accurate that before school starts that teaching staff, classified staff in our schools will be required to be tested?
So we are recommending that all staff be tested, and that's a matter of mutual benefit, because we are all potentially. It's the same reason we wear facial covering. I wear my covering to protect you. You wear your covering to protect me. And so it's a matter of community welfare and social responsibility. But in terms of the law and the question of what happens if someone refuses, I think we would try and exhaust every avenue around voluntary compliance, recognizing the mutual benefit for everyone. And the fact that someone who refuses testing may be putting their coworkers at risk. So my hope is that peer-to-peer conversations and institutional policies would support that. But it's not clear that we can, require if someone refuses a mandate. That may be different in setting of an outbreak. If there's an outbreak and someone, Lisa, do you have any?
Yeah, I was just about to add that would be different in an outbreak setting. If we had an outbreak at a school, we would work very closely with that school specifically to make sure all staff are tested and following the public health recommendations, or in that case, it would be orders. And again, in an effort to minimize the spread of any virus in that school community, and again, that's why we understand there's the elementary school environment is more suited to some of these more narrow cohorts that will allow us to kind of try and contain any possible spread as quickly as possible through testing. And testing is one of our key tools that we would, again, you might have seen, we have gone on site to different work sites to offer testing in the outbreak setting. And that's something that we're looking at, even building our capacity and expanding that capacity in Marin County, even beyond what you're seeing now around our testing capacity, because testing is one of our most critical tools to being able to quickly identify where there is risk of an outbreak and to literally nip it in the bud.
Can you just say a little more about face coverings? So let me just frame a myriad of concerns. The age of the children, there's some pediatricians that are saying it's not appropriate, right? That you should have little children, essentially wearing face coverings. Our recommendation that was going forward said we'd start at third grade and then up, and then with the younger children, we'd be going through the training and teaching time frame. Is it really, given the issues around carbon dioxide, et cetera, is it really safe for young children to be wearing face coverings?
So yeah, there's two. I mean, the question around safety and carbon dioxide is easier to answer, and the answer is that with facial covering, if it's a normal cloth or the surgical mask that we're recommending, as opposed to some more aggressive form of closure, that oxygen exchange is adequate and is sufficient, and it's safe. I think the more practical dilemma is how do you ensure facial covering for small children, and our earliest recommendations in Marin was children age 12 and younger was optional, and that was based on just again a sense of just behavior and feasibility. And the governor just came out with an order for across the state that everyone above age 2 is required to use facial covering. And so I think this is an area of really active dialogue right now at the state in terms of what does that actually mean. If for 3 and 4 year olds, the behavior to keep anyone really, but especially at that age, to actually keep that facial covering on, I think is, our perspective is that we should not expect that to be, we would not organize our strategies on the assumption that children of those ages will continuously wear facial covering.
Mm-hmm.
And just to add that the face covering really, again, we're seeing such minimal symptoms in children. So again, it's the mucus, it's the touching of the nose and the mucus and the coughing and the sneezing that the face covering is maintaining on the inside, that we are seeing significantly lower viral loads in children, as well as not the symptoms that manifest that expectoration of the mucus that carries the viral particles that makes them contagious. Mm-hmm. And so I think that's just, it's a tool, but I don't think it's, I think it will be the tool that we'll see evolve as the practicability of face coverings in young children is discussed at the state level.
So Jane, can I just offer that? The other thing about the facial covering, I think it raises another issue, which is the relationship between local and state directives. And, I think sometimes things that are coming down from the state are interpreted as being local or vice versa. And that's space that we're still trying to figure out, sort of how to navigate. Right now, we have essentially 2 separate recommendations around facial coverings operating in Marin County. The one that we offered, which is 12 and under, and then what the state just did with 2 and above. and so the, you know, that's something that I think every school and school district needs to be aware of, that we have our recommendations. We'll do everything we can to reconcile it with what the state is recommending, but the state changes, and sometimes there's these intervals where which one we point to might be a source of confusion.
Matt, we were just looking last night at a Harvard study that just came out, and dealing with this issue, they essentially recommended a strategy where you provide opportunities for kids to go outside, stay significantly distanced, to have breaks from their facial covering. So that might be something we think about. Lisa, you just used a word that is causing great frustration in our community and beyond. What, in goodness sake, does practicability mean? What's practicable? So everywhere people, you know, you look at CDC, you look at the public health for the state, you look at the CDE, and how do we think about that? What is that supposed to mean?
So the way I see it, again, it's that combination between practical and feasible. It was my favorite word last week because it's not a word I often write with. And I think that's where we really are looking at the schools and the districts themselves to take this guidance, to have conversations of what are the common sense approaches to implement the guidance to make sure, we create these safe environments. And again, I think that where the next question often goes to the distancing, why not six, it's always been 6 feet. Why are you allowing less than 6 feet? And again, I think that's where there is more risk if we're closer together. But again, with wearing face covers and other infection prevention and control strategies, we still are mitigating that risk, or reducing that risk as much as possible as from that. Again, what we're trying to do is prevent that virus particle that might be on one person or in one person getting onto the other person. And with improved respiratory etiquette, face coverings, the likelihood of that is decreasing significantly.
Okay, so let's just talk about, I think, Matt, this goes to you. How is it possible that you could switch and go against what everyone is saying, the 6 foot distancing? So, and that comes up in a myriad of questions that we have.
Yeah, I mean, so, the reality, this is partly related to the practicable question, which is, the reality is that when someone is infected with COVID-19 and they breathe into the environment, the virus particles distribute. If we're wearing a face covering, about 99% of those virus particles are blocked right off the bat. The vast majority of them, especially the heavier droplets that have the higher number of virus particles, go about 3 feet. From there, there's just a continuous decline, right? Nothing magic happens at 6 feet. It's not as though there's nothing at 7 or 8 or 9 or 10 feet. Nor is it that there is a little more at 5 feet than there was at 6. But this 6, this is one of the problems with the way public health offers recommendations, is that there's this sort of artificial sense of concreteness to some of these things that are continuum. So this is another element of the continuum of risk that I described. 10 feet would be a lot safer than 6 feet. And so how do we blend what's manageable in a global reduction, a harm reduction strategy that is global and holistic, taking into account, and it's difficult calculus, right? How do we take into account the social harms associated with distance learning and the inequitable distribution of that, with the relative difference between 5 or 6 feet in terms of virus transmission, right? So these are difficult, and I'm not pretending like this is a simple calculus, but I want to just offer the perspective that from a science standpoint, we're talking about, again, it's just a continuum of the reduction of the number of particles over a certain distance. And 6 feet has been offered by this World Health Organization, uses 1 meter. That's 3 feet, because they just draw that line in a different place on that continuum of virus distribution. And so and again, CDC offers it as a recommendation, not a requirement. California Department of Education, again, it's where it's feasible, 6 feet. California Department of Public Health, where it's feasible, 6 feet. And so those are, again, this is, it's more subjective.
Okay, so can you assure the public, whether it's the parents, the students, that in fact that our schools will be safe?
Safe? No. We can't guarantee safety in this era. I mean, I don't know if we can ever guarantee safety.
I was just going to add, I think we never can guarantee safety in the school environment. My bread and butter all year long before COVID is the outbreaks of disease in the school environment. Norovirus, strep, are kind of our two most common that we see. We do have those vaccine preventable diseases like measles and pertussis that we've been working with. So our human nature, our social interactions always expose us to viruses and bacteria. And again, I think that's where we're very focused on COVID-19, but one of the other points just to remember, and I had personal experience with this, my husband and I are both on the front lines going into nursing home settings. So we've had to test our children a couple of times for COVID-19 when they developed symptoms, and it was strep, they had strep. And I think that's going to be one of our challenges where we're going to be very laser focused on COVID. But to remember that all the other bugs, right now it's summer season, so we have enteroviruses, we have rhinoviruses, other coronaviruses circulating. And when we are testing people who are presenting with symptoms consistent with a viral infection, that most of the times it's not COVID-19 still in our community. And again, one of the silver linings with COVID-19 that I'm hoping to see is that we do have a reduction in some of the flu that we see in the winter seasons because we are being more vigilant around COVID-19. But I also know how quickly we are all too lax in some of our own protective measures. So I think, again, it's just really important to remember that we live among bacteria and viruses, and we're learning more about this. It was an unknown virus to us before. We're learning more about how to protect ourselves. But some of the same measures that we've discussed, how we protect ourselves against the flu, with the exception of the vaccine, are the same things we're protecting ourselves against COVID. And that will be also a challenge where we're going to be testing a lot of kids and they're going to be coming back with no COVID. And then we're also going to have another challenge where we'll be testing kids who test positive with COVID. They're going to be relatively healthy and asymptomatic, and your child who have to stay at home for 10 more days. And then the child who's recovered more quickly from the flu will be back into the school environment. So we're going to have just some of those challenges that we'll be navigating together.
Okay.
Mary Jane, I have just a quick follow-up on the question regarding 6 feet. The other really important factor is that where air can be distributed more, where we have dispersion of particles out of doors, that's another really important context for this, is that outdoor transmission is extremely limited, even at closer distances, but from the emerging evidence.
So there's multiple questions about people that live with someone who has underlying health conditions. So can you talk a little bit about that and what this level of opening schools exposure for students, staff, etc., but someone at home has underlying health conditions?
We've been working with this, again, with healthcare workers since the beginning in a lot of these same scenarios. And again, there's so much that you can do to protect yourself before you get back home from anywhere you're socially engaging, especially after a school day, where it's when you return home, making sure you take your clothes off from the school day, take a shower, washing yourself before you re-engage with the family. The things that we know we touch throughout the day, like our cell phones, making sure that we wipe down our cell phones and keys, the things that we bring into the house from the outside, and then starting that day again with hand washing. If basically, again, it's you trying not to take that particle and transmit it to a person that might be immunocompromised in your house. And again, vigorous hand hygiene and lotioning, because we don't want to dry your hands out throughout the day. Taking those shoes off and your clothes off and washing them, and taking a shower before you re-engage with the family. And that's what I do with my kids when they come home from camp. We might let them run a little bit outside, but then they or do their MMA and Zoom downstairs, and then they'll shower up first thing before they re-engage with us And that's what we do when we come home ourselves. So it's just, again, there's strategies that we all can do and that we probably are a little lazy with in general during any flu season.
Mary Jane, can I just reassure that, that a lot of these questions, I'm just looking at the questions that are coming in, and there's a lot of very specific and detailed questions that, and I think the way we've structured these conversations are to go through kind of different elements of the 30 recommendations we have. All the questions that have come up fit into one or another of those buckets, and we'll have more dedicated time to really parse this out and offer those answers in the coming weeks. You're muted.
We wouldn't want that, right? So thanks so much. Thank you, Dr. Willis. Thank you, Dr. Santor. We really appreciate it. We can barely wait for next Thursday at 9 o'clock to begin looking at the first components of the 30-point plan. For all of you on the phone, hopefully many of you are jumping onto a Zoom call that will be starting 2 minutes ago. So we're going to jump there, where we're going to be getting more information about the walkthroughs that are happening in our schools, so that people can take the necessary precautions, some of which were talked about just as part of this conversation. So thanks, everybody. Look forward to connecting with you again soon. Thank you, Matt. Thank you, Lisa. We appreciate it.
Thank you. Bye.